It's now my pleasure to introduce Dr. Jordan Nestor. Dr. Nestor is a nephrologist at Columbia University's Vagelos College of Medicine. She received her MD degree from the Albert Einstein College of Medicine at Yeshiva University in the Bronx, and then came into Manhattan and joined the internal medicine residency training program at New York Presbyterian Hospital's Weill Cornell program. And I'll always remember meeting Jordan on her first day of orientation as an intern. And she very proudly came up to me and said, I'm going to be a nephrologist. And so we've remained friends ever since then. Although I didn't get her to stay here for her fellowship training, but that's a different issue. She did go up to Columbia, where she trained, did her clinical fellowship, and then trained in research in Dr. Ali Garavi's lab. The discovery of APOL1, G1 and G2 alleles among individuals of West and Sub-Saharan African ancestry is associated with significant risk of kidney disease, as we'll talk more about in a bit. Dr. Nestor's clinical and research interests center on diagnosing and managing genetic forms of kidney disease, and her research focuses on expanding the routine use of genomic testing and of helping nephrologists who have limited experience utilize genomic data to personalize the care of their patients. And we hear certainly a lot more about personalized medicine today. And so, Dr. Nestor, we'll look forward to your talk about how we can improve patient care. And as Ms. Roberts said, put patients first in everything that we do. Thank you for joining us.
Thank you for having me. It's a real honor to be invited and, of course, to still be able to see Dr. Silversweig. Okay. So can you see my slides?
At the moment, we're just seeing you.
Okay. Okay. How about now?
Now we see it.
Okay, great. So my talk is about implementation of kidney genomics. I have nothing to disclose. Kidney disease exists on this spectrum, on a continuum. On one end, you've got very rare genetic causes where one change has a large effect size. The person is likely to have a kidney manifestation, a kidney phenotype. On the other side of this continuum, you've got complex diseases, polygenic diseases, where there's a combination of genetic risk factors and environmental factors in this whole world of interactions that we have yet to fully grasp, that modulate risk, and where cumulatively there are small effect sizes that lead to someone having a kidney phenotype like a chronic kidney disease. So I was in the Garavi laboratory when this paper came out. This was a landmark paper in our discipline about the use of exome sequencing in a research cohort. Specifically, there were over 2,000 individuals from Columbia University and 1,000 individuals from a Northern European cohort that was an ESRD cohort. Very importantly, these 3,000 plus patients had kidney disease of all types. And what was found is that nearly 1 in 10 individuals who underwent research-grade exome sequencing had a monogenic form of kidney disease, a monogenic nephropathy. And the diagnostic yield increased close to 20% for individuals who had kidney disease of unknown etiology, which really was the basis for why we started pushing the essentialness of considering genetics and hereditary nephropathies when evaluating patients with chronic kidney disease. Importantly, making a correct, timely diagnosis is essential for the personalization of care management and getting some insights about prognosis and any targeted surveillance of any extrarenal manifestations of some genomic syndromes. This is why KDIGO in 2021 recommended that if you are evaluating an individual with chronic kidney disease, to think genetics, and very importantly, try to obtain a family history whenever possible. And I'll just add, and it's not just the history of kidney disease you're considering. You want to know about anyone in the family who's died suddenly at a young age of unknown causes. You want to know of anyone who's had any malformations of their heart, their lung, their gastrointestinal systems, their kidney, and genitourinary tract infection, infertility. These are all insightful, especially if someone has a kidney disease that maybe is atypical or isn't very clear-cut in terms of manifestations. So I'm just going to give you some cases. This first one is a 39-year-old who's coming in for transplant evaluation for ADPKD. He was diagnosed 5 years prior when he had gross hematuria, and abdominal ultrasound showed bilateral kidney cysts. And importantly now, he has 3 siblings and a father who'd like to donate. His mother died at 42 from a motor vehicle accident. His father, who was with him, is 66 years old and healthy. He has 2 sisters who are younger than him and 1 brother also younger than him, all healthy and wanting to also be donors, and he has no children. Importantly, ADPKD is still a clinical diagnosis made based on radiographic evidence. And of course, if you make that diagnosis, there are surveillance and treatment options based on the clinical diagnosis of ADPKD. So the question is, why, if someone has ADPKD and it's diagnosed clinically, should genetic testing be considered? And that's because not all cystic syndromes of the kidney are ADPKD. And there are a lot of other genes associated with polycystic phenotypes that are potentially at play in someone with a familial disorder. Molecular testing can help pinpoint the correct genetic diagnosis and identify the right syndrome. Importantly, this is essential sometimes because ADPKD has its own genomics phenomenon, and so it has these extrarenal manifestations, just like these other genetic syndromes have as well. And so some of them have different organ involvement. They have different rates of progression, likelihood of progression in terms of end stage and end organ manifestations, and also different inheritance possibilities. And so that is why KDIGO then said, when a person has ADPKD and you really need a definitive diagnosis, genetic testing should be considered. So even though, again, it's a clinical diagnosis, there are reasons for why it should be done to establish the molecular basis for the disease when there is a reason. So for example, cysts develop with age in ADPKD, and this individual was the eldest of 3 siblings. And so because it is possible that the younger siblings have not yet manifested a kidney cystic phenotype yet, that maybe the most important donor, the most likely best suited donor in this case, should be the father if he has no evidence of disease. And so again, timely and accurate diagnosis is essential when you have any sort of vague or nonspecific kidney phenotype, because tailored therapies and tailored surveillance can really guide the personalization of care. Here, just a little summary for why. In this case, really it assists in the living organ donor selection among at-risk candidates and helps with extra-renal surveillance of other organ systems, and also helps guide family testing and, by establishing the molecular cause of this disease. This other case is a 35-year-old woman who was pregnant. She had hematuria. She was referred to us at 32 weeks gestation with 4 and abnormal urinalyses. 2 years prior, she had microscopic hematuria and proteinuria also evident in her urinalyses. And when we evaluated her this time, she had a serum creatinine of 1.1, elevated, of course, in a pregnant woman, and over a gram of protein. Unremarkable kidney ultrasound, and she underwent a kidney biopsy. First, a little history about her prior pregnancy. She had 2 prior pregnancies. One, the furthest away, was uncomplicated. The second one was induced at 34 weeks for quote-unquote preeclampsia. From her family history, we know her mother had glaucoma, and she had this young uncle who had hearing loss and died at a young age. During her intra-pregnancy kidney biopsy that was done, we found that she had these FSGS pattern lesions. And so importantly, FSGS lesions are a pattern of injury and nonspecific, but histopathologically, they've taken this disease entity and become this own disease category. And if you can't identify the cause of it, sometimes it is considered primary, and individuals will undergo treatment with immunosuppressants. However, if you identify that this phenotypic manifestation is related to a hereditary syndrome, and this is a genetic FSGS, for example, that would warrant much more conservative management. And so molecular testing in this case can really help differentiate your monogenic versus your acquired / polygenic forms of kidney disease. This individual was enrolled in that biobanking study that led to that New England Journal paper, and she was found to have a heterozygous splice site variant in the collagen 4A4 gene, which met classification criteria by the American College of Medical Genetics and Genomics as likely pathogenic, thus deemed causal. And so importantly, from the New England Journal paper, we found that we had 91 individuals in the Columbia cohort who had a pathogenic or likely pathogenic variant of the collagen 4A3, 4, or 5 gene. And interestingly enough, they presented quite heterogeneously. Some of them had FSGS pattern lesions on biopsy. Some of them presented more typically with the Alport syndrome spectrum of disorders. Others had glomerulopathies of unknown cause, and a proportion of them had kidney disease of unknown etiology. And so just to show you that the collagen 4A associated nephropathy, the Alport spectrum of diseases, can really have a variable phenotypic presentation with certain genetic changes causing more of the Alport-like presentation with hematuria, proteinuria, GFR, loss, decreasing renal insufficiency, plus minus hearing loss, plus minus some ocular malformations. And then on the other side, you can have really just isolated FSGS due to the impaired collagen molecules. And so this is very important because nephrologists might miss these diseases because they present atypically or subclinically, and a delayed diagnosis is a lost opportunity for early intervention. But it just shows that there's tremendous difficulty in identifying atypical or very subtle cases of these glomerular diseases or these monogenic nephropathies. For this case, establishing a diagnosis that this was in the Alport spectrum of diseases helped us avoid, it would have avoided a kidney biopsy had it been available commercially or clinically before her kidney biopsy. And it also guided therapy so that she wouldn't warrant immunosuppressive, and this wasn't considered a primary FSGS. Importantly, it guides one towards more conservative management, so RAS blockade and earlier referral to kidney transplantation if her kidney function declines over time. Also refer to audiology for assessment, a baseline assessment, because the suspected progression of sensory neural hearing loss, and then ophthalmologic evaluation specifically to look at retinal imaging because of ocular manifestations from this genetic disorder. Also, cascade screening of at-risk family members who might also carry the gene, the genetic variant. So another takeaway point in this is that hereditary kidney disease are clinically variable and they can be very difficult to recognize. Here, for this case, the genetic testing helped establish the molecular diagnosis, tailor therapy for more conservative management, avoiding immunosuppression. It would have avoided the kidney biopsy had it been available at the time. Based on the genetic change, sometimes you can have some insights into the progression of their disease and how quickly it'll progress. Someone who has a whole gene deletion, for example, of course, is suspected to progress a lot faster and have maybe the extra renal manifestations, helps guide family testing, assist in living organ donor selection, and assist in referring for kidney transplantation earlier, and of course, help with specific surveillance of the other organ manifestations of this genomic syndrome. And so after the New England Journal study, we had all these patients that we needed to return results to. And so it led to this study where we developed a clinical workflow for how we would return patients' results if they were in the research domain and they needed to undergo clinical retesting and informed consent, and how to counsel them and their nephrologists on what to do with those results, and then how to return results to patients who you order clinical genetic testing for. And so this was done iteratively based on these qualitative interviews, this iterative process of educating our faculty. And so this workflow was developed that's been quite helpful. So we have this established genetics clinic where I'm one of the 4 attendings who alternate seeing patients on a Friday afternoon with 2 genetic counselors, very talented Kelsey Bojo and Natalie Vina. Ali Garabi is now the chair of medicine at Columbia, so he's a little busy, and Christoph Kirluk is now the chief of the division, so he's a little busy. So it's really me and Simone Sanakaraki seeing a lot of these patients on Friday, and I'm more junior than both of them, so I'm seeing a lot of these patients. But it's a wonderful experience where we are seeing patients from across the country. As of earlier this year, we've seen over 1,000 individuals. I'm licensed in 4 states, so I can see a lot of these patients virtually. The majority of the patients we see are virtual. We have an overall 30% diagnostic yield, and we also return an additional 10% of these clinically meaningful genetic results, specifically APOL1, which sometimes nephrologists are eager to learn the status of in their patients. I will hold my questions answering for later if any of you have any questions, but thank you for listening.
Thanks so much, Dr. Nestor. That was a terrific talk, and I think really clinically valuable, and I think will help patients understand some of the benefits that may come to them from this type of genetic testing that otherwise they might not consider.